Welcome to 5 Steps to Rhythm Interpretation. My name is David Woodruff, the certification coach, and I'm going to talk with you about how to interpret rhythm strips. The 5 steps to rhythm strip interpretation include identifying the speed of the rhythm. So step 1 is, we ask, is the speed of the rhythm between 60 and 100? Step 2 is it regular? Step 3 is the complex narrow? Step 4, is it preceded by a P wave? Step 5, do all the complexes look the same? Those are the 5 steps we're going to use as we move through and we talk about rhythm strips. But first, some background. This picture here is showing the heart, and it's showing the conduction through the heart and how long it takes for that conduction to occur. Well, the impulse is originated in the SA node, so it makes sense that it's going to get to the SA node in 0.00 seconds, right? So it's there immediately. And then it's going to move down to the AV node in 0.3 seconds, and then it's going to move down into the ventricles. And as it moves through the ventricles, you see that there is a variable right there through the ventricles, anywhere between like 0.17 and 0.22 amount of time. But, 0.17 and 22 of a second is not very much. So you're not going to see much of a difference on your EKG. But we do see what's called the QRS complex. So we have enough of a differentiation in time there where that impulse is going down through the ventricle to create a complex, and that's what we call our QRS complex. The electrical pathway, again, we have 3 main pacemakers of the heart. The primary pacemaker is the SA node. We call that the pacer, the pacemaker of the heart, because it is the one that usually takes over. The reason why the SA node is usually the one to generate the impulse is because it's the fastest. The heart is going to follow the fastest pacemaker. So whichever one of these beats the fastest, or shoots out electrical impulses the fastest, is going to be the one that is followed. Now, this can create problems, as we'll see later. This can create problems if there's an impulse that's generated somewhere else in the heart that is faster than 60 to 100 per minute. Next, we have the AV node. Of course, the AV node is between the atria and the ventricles, and it runs at a rate of 40 to 60. It's not the primary pacemaker, again, because the SA node is faster. But the AV node can take over. If something were to happen to the SA node and it doesn't fire for some reason, the AV node can take over. We call this a nodal or a junctional rhythm. So the AV node has also been called the junction, so the AV junction. Hence, junctional rhythm. The bundle of His down in the ventricles can also pace the heart if need be. However, its rate is only 20 to 40. We typically call this an agonal rhythm when we see it in a patient. But that is where we're going to have our primary pacers. Again, the bundle of His, the AV node, typically are not our primary pacers. Our primary pacement comes from a SA node. Makes sense, it's the fastest. The components of the EKG include the P waves, which represents atrial depolarization, the QRS complex, which represents ventricular depolarization, the T wave, which represents ventricular repolarization, and a U wave, which is usually not there, but it could be part of our EKG. How come? Okay, you see, we see a T wave. T wave represents ventricular repolarization. Why don't we see some wave that represents atrial repolarization? The reason is that atrial repolarization occurs during ventricular depolarization. And since the QRS complex is much larger than the complex that would be originated or that would be generated by atrial repolarization, our atrial repolarization gets lost in the ventricular complex of the QRS. So we're not going to see atrial repolarization on our EKG because whatever wave is formed by the atria is so small that it gets lost in the QRS complex. Additional components that we look for when we're looking at an EKG include the PR interval. That's the time it takes for the signal to go from the atria to the ventricles. So between the P wave and the R wave, atria to ventricles. The ST segment, okay, so we're looking at the ST segment, which is our segment between ventricular depolarization and ventricular repolarization. Changes to that ST segment can indicate myocardial ischemia, injury, or infarction. The QT interval, look at the interval between the beginning of the QRS complex and the T wave. If it starts to lengthen, that could mean that your patient would be at risk for a ventricular dysrhythmia. Many reasons why the QT interval can lengthen. Primary ones are related to medications that we're giving to our cardiac patients. So here is an example of a QRS complex, and we see what's happening here as in relationship with the heart. So our P wave is the atrial depolarization, and then you see the PR interval as the interval between the P wave or the beginning of the P wave, I should say, and the beginning of the Q wave, or the QRS complex. So we're looking at the PR interval, and then we're looking at our QRS complex, or the amount of ventricular depolarization, and we're seeing how wide that is. The reason why we look at our QRS is to find out whether or not we are having some aberrant type of circulation through the ventricle. If that QRS complex starts to widen out, that could mean that we are having some aberrant conduction through the ventricle. Then we look at our ST segment. The primary reason we're looking at the ST segment is that we're looking to see whether or not that segment goes back to baseline. Baseline is what happened or what we had before the P wave. So when you're looking at this QRS complex here, go back to before the P wave, and that is where we want our baseline to come back to. So the baseline is literally the line that we started with before we had electrical activity. So on both of these EKGs, the one you see across the top, you see the baseline. The baseline is what comes before the P wave. And we should have our ST segment come back to the baseline. We should have the baseline come back to normal or back to where it started from after the T wave. And the same thing is happening here on the little diagram that is exploded that we're seeing here on the front. What is an EKG? I mean, we're looking at these things, trying to figure out what these things mean. Well, what exactly is an EKG? It's a picture of the electrical conduction, the electrical activity of the heart. It does not tell you about mechanical function. It tells you about electrical function of the heart. Patient may have a sinus rhythm, which is a normal rhythm, and yet be having some severe mechanical problems of the heart. On the other hand, we could have no mechanical function at all and still have an EKG waveform, because the EKG waveform is simply electrical activity in the heart. So although we use the EKG to help us to be able to find cardiac problems in our patient, that's not the only indicator we want to be looking at. We want to be looking at more of an assessment of our patient than just the EKG. So we want to do a full cardiac assessment. EKG is just one piece of that. Now, you've heard of people talking about the leads. Well, what is this whole idea of leads all about? Basically, leads are the areas of the body where we are going to put some kind of electrical conducting device to be able to read the electrical activity of the heart. So in other words, we can move those things around. Typically, we use some kind of adhesive that's got a little gel on the other side of it, and we stick it to the patient, and then we connect a wire to it, which is connected to our EKG monitor. The EKG monitor is detecting electrical activity that it puts into a waveform. As I mentioned already, if we change those leads, move them around from one place to another, we are going to be looking at the heart from different angles. So when we talk about using different leads, or somebody tells you about a 12-lead EKG, we're talking about having different ways of looking at the heart from different views. Imagine it this way. Imagine that you're walking around your house. As you walk around your house and look at your house, you're going to see your house in different perspectives. It's going to look different than in the back than it does in the front, right? Same thing is true with the heart. The heart's going to look different in the back than it does in the front. That's why we need different leads, so we can look at the heart in different ways, from the bottom, from the sides, in different ways, so that we can see different parts of the heart to be able to tell if there's damage or there's something going on. The most common lead that we use is lead 2. That's where we have the positive electrode on the left leg, and we're looking from the right shoulder to the left leg. So that's what this diagram is illustrating here. And it's put in some pieces that are electrical kind of concepts here. So we have our positive in the left leg or the left lower chest, and we have our negative in the right arm or right upper chest. Other leads we can look at lead 1, 2, AVR, AVL, AVF, and the chest leads, which are V1 through V6. Once we have some electrical activity, we're going to put that electrical activity onto a graph. Now, this graph comes out of your EKG machine at a regular rate. The complexes that show up on your EKG machine, if you're looking at it on the screen, are showing up at a regular rate, as if it's printing it out on paper. So it's not just randomly shooting those complexes across. It's putting them across at a regular rate so that we can see how many complexes occur per second. And in fact, on paper, you'll notice these little marks at the top. Those are 3-second markers. So there's little black vertical lines that are on the paper. And those are called the 3-second markers. So if we want to be able to find out what a patient's rate is, what we can do is we can look at how many complexes fall between 2 sets of 3-second markers. Well, why 2 sets? Makes it easier to multiply. So if we have 2 sets, we have 6 seconds, and we multiply it by 10, we have 60 seconds. So if there are 5 complexes in that 6-second strip, and multiply it by 10, we have a rate of 50. Makes it easy to do. This EKG strip is then further divided, as you see in the blow-up here in the front. It's further divided into additional components here. So you see the 0.2 seconds that's between the two big lines, the heavier lines, and each one of the small lines is 0.04 seconds. Okay, so that's important because if we're measuring what our PR interval is and our QRS interval is, we need to be able to have a way to measure it on that graph paper. So that's why we're using that graph paper, because it is standardized so that each little block is 0.04 seconds and each big block is 0.2 seconds. So here's a normal PR interval, normal QRS interval. The normal PR interval is 0.12 to 0.20. Normal QRS interval, 0.04 to 0.08. So let's take a look at our examples up above. So up above we have, and it's listed there under number 2. So you see the beginning of the P wave to the beginning of the Q wave. So we have a PR interval of, let's march it out here. So each one of those little boxes, so 1, 2, 3, and a half little boxes. Each little box is worth 0.04. So that gives us about a 0.14 PR interval. QRS interval, so we're looking at the amount of space there between the beginning of the QRS to the end of the QRS. Now, we don't have that marked out there on this particular diagram, but it looks like we're going a little bit more than 0.04. Okay, 0.04 would be one of those small boxes, and it's a little bit bigger than one small box, maybe a box and a quarter. So probably about a 0.05, 0.06, something like that. It's not to the point of 0.08, so it's not that wide. So then let's take a look at some of the rhythms and talk about how we're going to use our 5 steps to find the difference in these rhythms. So the first step is we're looking to see whether or not there is what the rate is. So we're looking to find the rate. So our first rhythm here is normal sinus rhythm. And let's find out why we call it that. So let's use our 5 steps. The first step is, let's take a look at the speed of this rhythm. Now we're going to assume that all of these strips that you see here in front of you, we're going to assume that all of them are 6-second strips. Remember again, on a 6-second strip, we can count the number of complexes that are in those 6 seconds and multiply it by 10. So here we have 6 complexes on a 6-second strip. So we multiply it by 10 and we have a rate of 60. All right, well, that's a normal rate, 60 to 100 beats per minute. Next, we're looking to see whether or not it's regular. Yes, it is regular. It's firing off regularly, and you're going to see some examples of ones that are not regular, and then that'll really point itself out. You'll say, oh boy, I can understand what's regular and what's not. Are all the complexes preceded by a P wave? Well, yes, in fact, they are. So there is a P wave in front of all of the complexes. Are the complexes narrow? Well, yes, in fact, they are. They are narrow complexes. If we were to measure them out, we'd probably find that they're about a 0.06, which is a normal QRS complex. And lastly, do all the complexes look the same? Well, yes, they do. Okay, so that's what we would call a sinus rhythm. We have a P wave. We have a QRS. So it's coming from the atria. It's a sinus rhythm. And we call it a normal sinus rhythm because it has all of those 5 components. The rate is 60 to 100. It's regular. The complexes are preceded by a P wave. They all look the same. And the complex is narrow. So it's following a normal conduction pattern through the heart. In sinus rhythms, we treat the underlying condition if the patient is symptomatic. Now, in a normal sinus rhythm, we would anticipate there's no treatment because it's normal. So it's what we expect to find. However, sinus rhythms can also be too fast or too slow. In this case here, we have a rhythm that is fast. So let's take a look at this one. And if we count this one out, again, assuming it's a 6-second strip, we have 12 complexes. Multiply it by 10, that's a rate of 120. Okay, so our rate of 120, that's faster than our 60 to 100, so we have tachycardia. Now, on this EKG, it may be harder to see the P wave. If you look at the complex that's marked, the second one there that's marked, and you can see there's a P wave that precedes the QRS complex. Okay, so there's a P wave. The QRS complex is not wide. And we have kind of a depressed ST segment, so it makes it look like it might be a little wide. So the T wave or the QRS complex is not wide. all the complexes look the same, and the rhythm is regular. So 4 out of the 5 components are okay. The one that isn't is our fast rate. So we would call this a sinus tachycardia. Sinus tachycardias typically are going to be caused by some underlying condition like a fever or exercise or something like that. So it's usually not associated with anything that's really harmful, although it could be a myocardial ischemia that's causing some sinus tachycardia. But this is not the kind of rhythm that we're going to run out and try and treat. We're not going to give medications and try and slow it down or anything like that. What we're going to do is try and treat the underlying problem. So if the patient is just exercised, have them sit down and rest for a few minutes. If it's pain, let's treat the pain. Hypovolemia, treat the volume, etc. The clinical significance of a sinus tachycardia could be dizziness and hypotension. Now, the decreased cardiac output piece or the increased myocardial oxygen consumption, those situations are likely to happen in people who have underlying cardiac disease. It's not likely that healthy people are going to have these kind of symptoms as a result of a sinus tachycardia. We want to treat the underlying cause. The underlying cause usually is going to be that the patient's having pain, the patient is having a fever, so we want to treat those problems. On the other hand, we can have a sinus rhythm that is too slow, and that's a sinus bradycardia. So let's take a look at our EKG. In this case here, now, assuming again a 6-second strip, we have 4 complexes. So we have a rate of 40. We have a rate of 40. That's slower than 60 to 100. However, we do have a P wave. The complex is narrow. The complexes all look the same, and they are regular. So we would call that a sinus bradycardia. The only thing that's abnormal here is the rate. The complex is normal. The rhythm is regular. So this is a sinus bradycardia. Some clinical associations could be a response to hypothermia, increased vagal tone. In most cases, it's going to be people who are athletes or who maybe have conditioned their bodies a little bit so that their heart rate slows down. Could be some disease states like hypothyroidism, though, so we would want to follow up. And definitely, if your patient does not look well with a sinus bradycardia, we're going to want to delve in a little bit deeper. Increased intracranial pressure is one of the things that can be very acute to cause a sinus bradycardia. Clinical significance would be, well, if the heart is beating at 40 beats a minute, there's a good chance that we're not having a sufficient amount of cardiac output in order to be able to maintain perfusion of the periphery. So the hypotension and perfusion part could be very significant. The treatment is going to be that we want to speed up the heart. We'll probably put a temporary pacemaker, at least until we can get a permanent pacemaker in place, and find out what the problem is, especially if we don't know what the problem is or if the problem we know is being caused by some myocardial disease. We'll definitely look at a pacemaker. In the meantime, maybe give some atropine to try and speed up the heart. Atrial flutter. This is an interesting looking EKG, isn't it? Now again, if we're assuming this is a 6-second strip, we count out our EKG and we find out we have a rate of 40, maybe 50 if you want to count that one that's at the very end there. So still, it's less than 60, so we have a slow rate. Look at our QRS complex. The QRS complex is narrow and it's regular. Okay, so those things are good, but do we have a P wave that precedes each QRS complex? Well, on initial look, it might say, well, yeah, it kind of looks like a P wave there, right? But then what do you call the things that are going in front of it? So instead of having P waves, what we have is what's called a flutter wave. Flutter waves are represented by a capital F. Now, we'll see, we're going to distinguish that later from fibrillation waves, which are lowercase f. So in this case here, we have that sawtooth-shaped flutter wave that's occurring before the QRS complex. In atrial flutter, usually we're going to have a regular ventricular response. Typically, atrial flutter is going to originate from a single ectopic focus in the heart. So some of the things that are some of the etiology for atrial flutter include coronary artery disease, hypertension, mitral valve disorders, pulmonary embolus, chronic lung disease, cardiomyopathies, etc. The clinical significance is that we can lose our atrial kick either from a high ventricular rate or a low ventricular rate in the one we saw here. So if those, you notice those flutter waves were pretty fast. So if those flutter waves start conducting, in the case of the EKG that we saw, there was about a 4-to-1 conduction. So 4 of those little flutter waves and then 1 ventricular response. If those become conducted more frequently, though, then we can end up having a very fast ventricular response, and that could end up causing a decrease in cardiac output, which could either then cause a low blood pressure or maybe precipitate heart failure or angina in our patient. Because the atria are not conducting and contracting in a normal way, blood is going to tend to become turbulent in the atria, and there is a risk that thrombi are going to form in the atria as a result of this dysrhythmia. The treatment goal is to make sure that the ventricular response does not become too fast. Okay, I want to try in by increasing the block in the AV node if that's necessary, using calcium channel blockers or beta adrenergic blockers. Electrical cardioversion may be necessary. In many cases, what we'll do is just allow the patient to have this dysrhythmia so long as their ventricular response is within a fairly normal range and they're able to have a normal cardiac output. But we do want to anticoagulate to try and prevent that thrombus formation. So the primary goal is to slow that ventricular response. They may do some radio frequency catheter ablation or to try and basically what they do is they burn that area of the heart so that they can try to prevent that area of the heart from beating and causing those little flutter waves. And then the AV node will take back over again. Atrial fibrillation, on the other hand, we saw the sawtooth pattern that we had in atrial flutter. In atrial fibrillation, we have total disorganization of atrial electrical activity due to multiple ectopic foci that are resulting in a loss of having a good, strong atrial contraction. We've completely lost our atrial kick. That means we're going to lose at least 30% of the blood that's getting to the ventricle. So in other words, we'll lose about 30% of our cardiac output as a result of not having the atrial kick and atrial flutter, or fibrillation, I'm sorry. This is a picture here of a patient who may have atrial fibrillation. Again, we're going to start out with the ventricular response. We notice the ventricular rate in this case is about 50, so 5 complexes times 10. When we're looking for the P wave, you notice there's nothing there that really looks like a P wave all the way through. If you look at the third complex, you may say, well, that kind of looks like a P wave there right before that QRS complex. But do you see the same thing anywhere else? No, they're not the same. Instead, what we're seeing is lots of little waves, and they call those the lowercase f waves, the fibrillation waves, that are in front of each QRS complex. So there's nothing there that is really being conducted and causing a normal type of a rhythm. The problem with atrial fibrillation, again, is like with atrial flutter, You see all those little complexes in front of the QRS. If more of those start becoming conducted down to the ventricle, that means we can have a very fast ventricular response. Atrial fibrillation often occurs with underlying heart disease, with cardiomyopathies, heart failure, and pericarditis. Other diseases and conditions that can cause atrial fibrillation? Very often electrolyte disturbances. The risk of atrial fibrillation increases by 10% for every decade after the age of 50. So the clinical significance is that we have a decrease in cardiac output. We've lost our atrial kick, and we may have a very rapid ventricular response. Those things can result in having a decrease in cardiac output. The other problem, of course, is that those thrombi can form in the atria. Just like an atrial flutter, we can have thrombi forming in the atria because the atria basically are not contracting. They're just kind of sitting there and quivering, and so blood can become stagnant and form into clots in the atria. So our goals of therapy is to decrease the ventricular response, so we want to control that ventricular response, and prevent a stroke by anticoagulating the patient. In some cases, we may want to try to convert the patient to sinus rhythm. However, we found that either using a chemical cardioversion or electrical cardioversion, in many cases, causes more damage than it does to just allow the patient to have atrial fibrillation and control the rate and prevent clots from forming. So here again, it's just talking about the patient with atrial fib that we want to anticoagulate them prior to the patient getting a successful cardioversion. Some other possibilities, again, radiofrequency catheter ablation. So again, what they're doing is they're going in either with radiofrequency, the catheter, or they're going to go in with using a severely cold cryoablation or heat, a high-intensity ultrasound, to burn that area of the heart where all of these aberrant electrical activities are coming from. Moving away from the atria as such, we move into our paroxysmal supraventricular tachycardia, or PSVT. This originates in an ectopic focus anywhere above that bundle of His. What happens here, now this is paroxysmal, which means that it's not continuous. So we have a run of repeated premature beats that is initiated by a PAC, a premature atrial contraction. So it'll start and stop just on its own. The number of beats may be 10, maybe 15, 20, but it starts and stops on its own. There may be some degree of AV block, which causes this. We can also have the situation called Wolff-Parkinson-White syndrome, which is a type of PSVT that can happen in our patients as well. Treatment's a little bit different. So here's an example of PSVT. Now notice on the left-hand side, we have our fairly normal EKG. You see the P wave, QRS complex. We do have an inverted ST segment. So there may be something going on there. Maybe the patient is having some cardiac ischemia. However, then the patient goes into, and you notice between the first and second complex, look how long that spacing is. So we're trying to be able to determine the rate of this rhythm here. You see that the rate is very slow over on that left-hand side. Then suddenly, boom, 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 we get all these very fast beats. And then at the end there, it stops. One other thing to take a look at is I mentioned that PSVT is precipitated by a PAC. Over on the left-hand side, the first one of these abnormal beats looks different from the rest of them. just a little bit. Okay, but it looks a little different than the rest of them. That's your PAC, and it's stimulating this PSVT. And then you notice it just stops on its own. And we go back to the underlying rhythm that was there. So in a normal heart, maybe somebody who does not have underlying cardiac disease, if a patient's using a lot of stimulants, maybe the patient is having some problem with asthma and they're taking a lot of asthma medications, add to that some overexertion and stress, and those things could stimulate the heart, or I guess overstimulate the heart, so the patient goes into PSVT. Digitoxicity can also cause PSVT. Otherwise, it's going to be probably in a patient who has coronary artery disease. The clinical significance is that these episodes, especially if it's prolonged, can decrease cardiac output, and the patient then may not be getting enough perfusion to the periphery. And if the patient has underlying disease, they may not have enough perfusion to the heart. So our treatment is, first of all, a vagal removal. Oh my gosh. Let's just stop and knock that out. So treatment then would be a vagal maneuver, like a Valsalva or coughing. We want to try to get some increased intracranial. Fuck, again? So the treatment then includes vagal maneuvers like a Valsalva or coughing. The idea is to increase intrathoracic pressure, which will help to decrease that heart rate. IV adenosine would be another method of slowing the heart down. Basically what that does is it stops the heart for a second or two, allowing the electrical conduction of the heart to take back over with a normal conduction pathway, i.e. the SA node. DC cardioversion. In Wolff-Parkinson-White syndrome, we're going to use a radiofrequency catheter ablation. Junctional dysrhythmias. So I mentioned this before. Sometimes they're called junctional, sometimes they're called nodal. We're talking about any kind of dysrhythmia that originates from the AV node. In order to have a junctional rhythm, the SA node has failed to fire. There's something wrong with the SA node. Otherwise, the SA node would be firing the heart. So the AV node is taking over because the SA node has failed to do its job. This is a junctional dysrhythmia. Okay, now again, assuming a 6-second strip here, we have two complexes, so we have a rate of 20. That's really slow. You notice there's no P waves in front of the QRS complex. That means it's not coming from the SA node. It's not coming from the atria. So it's coming from the AV node. Junctional dysrhythmias are usually associated with some kind of underlying cardiac disease. So look for the underlying cardiac disease. Electrolyte imbalance is also a big problem here too. So I'll be looking for those, the inferior wall MI, and medications. You know, some of the medications we give to our patients can really cause some dysrhythmias. We have to be careful. The clinical significance, well, the main clinical significance is it may be too slow in order to maintain a normal cardiac output, and the patient may end up developing heart failure. So our treatment is going to be, if it's symptomatic, we're going to give atropine. Obviously, we're going to hold DIG if the patient's on digoxin. And we may have to give something like a beta-adrenergic blocker or calcium channel blockers, amiodarone, in order to prevent further dysrhythmias. Also occurring in the AV node or the junctional node is a first-degree AV block. So now we're going to talk a little bit about these blocks. There's a first, a second, actually 2 seconds, and a third-degree AV block. The first-degree AV block is generally considered to be benign. Let's take a look at it here. A first-degree AV block means that the duration of the PR interval is prolonged. Look at the PR interval in this EKG. Now, the third complex is probably the easiest one to see it. And you see the PR interval spans almost 2 large boxes. Each large box is 0.20, so it's about twice as long as it should be. So what can cause a first-degree block? Well, it could be MI, it could be coronary artery disease, but some people, and especially in asthmatics, we see a lot of first-degree blocks that are totally benign. It doesn't mean anything for them. It's just kind of a function of asthma. If the patient is taking medications, that's something else we want to consider, because DIG and beta blockers could be causing the patient to have a first-degree block. The clinical significance, it's usually asymptomatic, but it may progress into a second or third-degree block. So that's what we're really concerned with. If this is somebody who is not on any medications and we think it's associated with asthma, those type don't progress. That's just kind of an underlying first-degree AV block as a result of having asthma. But if your patient is taking medications and has a first-degree block, that may progress into a second or third-degree block. Speaking of second-degree blocks, the first one we have is called a Mobitz 1, also called a Winky Bach. In this case here, we have a gradual lengthening of the PR interval. Remember, in a first-degree block, we had a prolonged PR interval. So we have a gradual lengthening of the PR interval until a QRS complex is completely blocked and doesn't occur. So let's take a look at what that looks like. So here you see the PR interval, and we're looking at, forget that first complex way over on the left. It's kind of half cut off anyway, and we need the PRs. So take a look at the PR interval in the second complex. It's kind of long. Third complex is longer yet. Fourth complex, there's an entirely missing QRS there, right? So you see a P wave, and it's marked. So P wave, P wave. The third P wave has no QRS. And then we move into the fourth complex, where now we're back to a short PR interval. And then you see the last complex has a longer PR interval. So we get a progressively longer PR interval until we drop a QRS complex. Associated with medications such as digoxin, may also be associated with coronary artery disease and other diseases that can slow our AV conduction. Usually the result of a patient having a myocardial infarction or acute coronary syndrome, and could very well be transient. But there's the possibility it could progress. So we want to watch, and we want to keep assessing that Winky Bach. If it's symptomatic again, meaning that the patient's blood pressure is low and they are having symptoms of a low blood pressure, then we may want to give some atropine or put in a temporary pacemaker in order to increase the heart rate. If it is symptomatic, we want to monitor and possibly have a transcutaneous pacemaker on standby. Another type of a second-degree AV block is the Mobitz 2. In this case here, we have a P wave that is non-conducted without a progressive PR interval. So when you take a look at this type of second-degree block, now you notice that there is, and let's forget the first spot it says blocked QRS, because we can't see the previous complexes. So let's take a look at the second complex. PR interval looks the same as the third complex, right? So they look the same. And then we have another P and a blocked QRS. So we don't have a gradual lengthening of our PR interval, so it's not a winky block. It is just a simple type 2 second-degree AV block. Again, associated with myocardial disease and DIG toxicity. The significance is that this type of AV block often progresses to a third-degree heart block. Okay, so this, when we look at a winky block, that's maybe something that is not as, we're not as concerned with. But this oftentimes is going to progress into a third-degree block and often will result in having a decreased cardiac output as a result. So the treatment is going to be a pacemaker. We need a pacemaker so we can start pacing this guy. We don't want to wait for his heart to keep slowing down. 2, a third-degree block. Now all of the impulses from the atria, they're just chipping away up there. They're doing their thing, but none of them are conducted to the ventricle. So the atria is doing its thing, the ventricle is doing its thing, and there is no communication. All right, now let's take a look at this strip here. Remember, again, the first thing we look at is the rate. We have 2 complexes on a 6-second strip. That means we have a rate of 20. Oh, that's not good. We need to have a much faster rate than that. Okay, let's take a look at all those P waves. We have P waves marching through all over the place, right? The P waves are much faster than the ventricular rate. So the P waves and the QRS complex have no relationship to each other. And that is a third-degree heart block. This happens in patients who have severe heart disease, systemic diseases, drug overdoses. The clinical significance is, in most cases of a third-degree heart block, cardiac output will be decreased. So that rhythm you saw of the 20 beats per minute, that's what we call an agonal rhythm. That rhythm is just designed to keep the person alive long enough for medical attention. So we've been able to evolve to a place where our heart is able to keep us alive with an agonal rhythm long enough, so hopefully we can get some definitive care and improve that heart rate. Because the treatment will be pacemaker. Once again, we may try some atropine, some epinephrine, try and increase the rate in the meantime, but pacemaker is going to be the main thing here. Now moving down into our ventricular rhythms, we have ventricular tachycardia. In ventricular tachycardia, we consider this to be a run of 3 or more PVCs to be called ventricular tachycardia. There are many different types of ventricular tachycardia: monomorphic, polymorphic, sustained, and non-sustained. So we can get little bursts of VT. We can get sustained VT. Just because a patient has ventricular tachycardia does not mean that they are unstable. So we need to find out whether or not this patient is stable. Unfortunately, ventricular tachycardia often will deteriorate into ventricular fibrillation. And now we move into the ventricles with ventricular tachycardia. Ventricular tachycardia is termed as such because the impulse is originating in the ventricle. And, as you can see from this strip here, we have a very fast rate. So as you go through and you look at the rate there, we have a very fast rate. It's greater than 100 a minute. Therefore, we have a tachycardia, and this is coming from the ventricle because there is no P wave preceding the QRS, and the QRS complexes are not narrow. Remember, those were a couple of the 2 conditions we were looking for as part of our 5 steps to rhythm strip interpretation. Is there a P before each QRS, and are the complexes narrow? Now, this particular VTAC is fairly regular, so we could say yes to that. But we have a wide complex, and there's no P before each QRS complex, and the rhythm is also not between 60 and 100. So we have a tachycardia, and it's coming from the ventricle. This is another type of VTach. VTach, as we said, could be monomorphic or it could be polymorphic. In this case here, it's polymorphic, meaning that there is more than one way that the VTach is shaped. So if you look over toward the right side, that looks like a fairly stable shape. It's a fairly consistent shape. Over toward the left, we start out with one kind of complex, move into another, move into yet a third and fourth complex type, and then we move into this stuff in the very middle. The stuff in the very middle is really becoming disorganized. And this may, in fact, instead of being VTach, it may be ventricular fibrillation. But for the purposes of argument here, we're going to say that this is a VTach all the way across. It's polymorphic, meaning it's coming from various places in the ventricle. That's where the impulse originates. Conditions that are associated with VTach include those conditions of the coronary system, so the coronary artery disease, acute coronary syndrome, myocardial infarctions, etc., cardiomyopathies, obviously, electrolyte imbalances. So if we have a fairly healthy patient here who doesn't have a history of cardiac disease, let's look for an electrolyte imbalance. A severe electrolyte imbalance can cause ventricular tachycardia. Remember again, as we were looking very early on in this program, we looked at the different electrolytes that are needed in order to have that action potential. And if those electrolytes are not in the right balance, then what can happen is the patient can develop a ventricular tachycardia. As I mentioned before, VTach can be stable. Just because we have VTach does not mean it's unstable. But it can also be unstable where a patient does not have a pulse. When we talk about stable and unstable VT, we're talking about whether the patient has a pulse or not. If you can't feel a pulse, then the cardiac output is so low, we call that an unstable ventricular tachycardia. Sustained VT can cause a severe decrease in cardiac output. So if we just have a little run of VT, well, that is concerning, but the cardiac output probably did not go down significantly for any significant period of time. That may have dropped, obviously, during that period of time. If we could see the patient's cardiac output during that little run of VTach, we would say, oh, wow, it did decrease, but we may not see it symptomatically. If the patient has an unstable VTach, we can see hypotension, obviously, that's the part that's making it unstable, pulmonary edema, decreased cerebral blood flow, so changes in mental status, and it can lead to ventricular fibrillation, which is cardiopulmonary arrest. Clinical significance, the treatment for VT must be rapid. Okay, this is a situation where the patient is at least potentially not going to have a good cardiac output. In fact, the patient may go into cardiopulmonary arrest. So we want to have rapid treatment for VTach. And the treatment, or I should say, the VTach may reoccur. The treatment is to treat the precipitating cause. So if the patient's having an MI, let's treat the MI. Let's treat the electrolyte disorders, etc. And a monomorphic VTach, which would be considered to be a little bit more stable than a polymorphic VTach. We would start with some medications. If it's unstable or we have poor left ventricular function, which is often the case. So patients who have VTach are patients usually who have underlying cardiac disease. That's why in a lot of our patients who have poor left ventricular function, they will put in a pacer, an AICD pacer, so that we can shock this patient when they go into VTach, or if they go into VTach, because those are patients who are prone to developing VTach. If it's polymorphic, we're going to get a little bit more aggressive here, and cardioversion may be used if our drug therapy is not effective. When we're talking about cardioversion, I just want you to be clear that cardioversion can be chemically, or like using medications, or it can be electrical. So we could use an electrical cardioversion, which is shocking the patient, versus a chemical cardioversion, which is using medications. If we have a prolonged baseline QT interval in a polymorphic VTAC, we might consider using IV magnesium or Isoprel, or some other medications may be used as well. So that's a little bit more of an unusual VTAC, which may have a little bit of an unusual treatment. Drugs that prolong the QT interval should be discontinued. And if we've tried the medications first and we're not getting a conversion, then we may have to move into an electrical cardioversion. VTAC without a pulse is a life-threatening situation. So we do want to be careful with our patients who are pulseless. So we can have a life-threatening situation. So we'll start CPR with defibrillate and move into epinephrine. VTAC can deteriorate into ventricular fibrillation. Typically, VFib is a type of a rhythm that occurs as a result of decompensation. So people walking down the street just don't go into VFib. They go into VTAC and then they deteriorate into VFib. In this situation now, in ventricular fibrillation, the heart is just basically quivering, and there's no contraction that's occurring here because we have all sorts of little pacemakers that are firing off, trying to get the heart to restart. The problem is all of those impulses all over the place are causing localized contraction or localized depolarization, but they're not depolarizing the entire heart. In VTAC, we had an aberrant pacemaker that was firing off the heart and getting it to contract. Now, again, we lose our atrial kick, but at least we had the ventricular contraction. In this case here, though, in ventricular fibrillation, the heart is just sitting there quivering because these little impulses that are shooting off all over the place are not actually causing a contraction. Ventricular fibrillation can be fine or coarse. This is an example of coarse ventricular fibrillation. No two complexes in ventricular fibrillation will look the same. Now, in this case here, when we have a coarse ventricular fibrillation, chances are that that impulse is moving further around the ventricle than it is in fine VFib. In fine VFib, those electrical impulses are probably not going very far. Ventricular fibrillation can be caused by a patient who has an acute MI. We're looking for that underlying cardiac problem. People, again, just don't walk into VFib. They just, walking down the street and boom, they go into VFib. That's not likely. What happens is the patient has underlying cardiac disease of some sort, and that predisposes them to developing VFib. Patients who have hyperkalemia or severe hypoxia, acidosis, those patients could go into a ventricular fibrillation. Again, usually precipitated by some VTAC. But those are situations where we have such a poor environment for the heart to try to function that the heart just starts to go into VTAC or VFib as the heart is no longer able to function normally because of that severe situation, the acidosis, the hypoxemia, the hyperkalemia. The clinical significance is that the patient does not have a blood pressure and a pulse. We are circulating, if we're circulating anything at all at this point, blood that is unoxygenated with no blood pressure and no pulse. So really we have clinical death. Treatment is CPR, so we start right away with CPR. We will try defibrillating. Hopefully that will help, but usually a couple rounds of CPR, a couple rounds of CPR actually do improve our outcomes with defibrillation, and we'll see that the patient will convert much better if we are doing some CPR first. If there is no electrical activity of the heart, we call that a systole. Previously, we talked about that baseline that our EKG goes back to. So our EKG goes back to this baseline, and we have our impulses going up and down from that baseline. A systole will just be a baseline. There is no electrical activity that's going on here. Since there's no electrical activity, then there is no ventricular contraction. There's no cardiac output. So in a systole, we want to try to get that heart restarted. Clinical associations, advanced cardiac disease. And again, people don't typically go into a systole. This is usually a situation where the patient has deteriorated. They went into VTAC, then they went into VFib, and now they're in a systole. So they decompensated down to a systole. Because of that, we're going to usually start with doing some CPR. The patient's unresponsive, pulseless, they're not breathing. Prognosis for systole is extremely poor. And the reason for that is, again, that a systole is a rhythm we decompensate into. So CPR first, intubate, maybe do some transcutaneous pacing if we can get the heart to respond to that, some epinephrine. So we're doing all of those things first in a systole. Another situation that can occur is called pulseless electrical activity. In this situation here, we have electrical activity of the heart, but there's no mechanical activity. All right, now I want you to think about this for a minute. Electrical activity and mechanical activity are two separate things. We can have electrical activity of the heart, but the heart doesn't respond and contract. Some reasons for that could be severe hypoxia, hypovolemia, severe electrolyte disorders, or we may have things that are impacting the myocardium. A cardiac tamponade, for example, where we have so much blood in that pericardial sac that we're compressing the heart, and now the heart can no longer contract. We still have electrical activity. The electrical activity is still going, but we can't contract because there is too much pressure around the outside of the heart from that tamponade. Tension pneumothorax, same kind of situation where we have pressure that has built up in the thorax, it's compressed the heart cannot contract. Pulmonary emboli can also cause pulseless electrical activity because we have too much back pressure on the right side of the heart for the heart to be able to pump, and of course we're also going to end up with some hypoxemia as a result of that. So our treatment is CPR, and we need to correct the underlying cause. That's the big thing. We can do CPR, we can intubate, we can give an epinephrine, and we can go on and on and on. But until we correct that underlying cause, so remove the blood from the tamponade, correct the tension pneumothorax, correct the electrolyte disorders, etc., until we do that, this patient is not going to start to improve. Prognosis of pulseless electrical activity will depend upon whether or not that patient gets prompt treatment for the underlying cause. Well, thank you for joining me for the 5 steps to rhythm strip interpretation. My name is David Woodruff, and until next time, bye now.